Dear friends, thank you very much for joining us for today's academic session. It's part of the Department of Medicine and CMC Fellows academic talks, which we call Department of Medicine academic lunch talks, though it's not lunchtime. And it is my great pleasure to introduce Dr. A.T. Prabhakar. Prabhakar is a student of CMC for undergraduate and postgraduate, and it is DM Neurology as well in CMC. Now he's a professor of neurology. He's one of our go-to doctors for any clinical problems. He's always available. He comes, he examines, he teaches the undergraduates and postgraduates, as well as faculty, the approach to the patient. And he's always kind and willing to explain at a simple level, though his knowledge is vast. So it's a great honor today to have Prabhakar to teach us. Prabhakar also has been instrumental in arranging a series of lectures which we're going to have over the 9 to 12 weeks. Every week we'll have different classes on different aspects of neurology. The talks are aimed at a postgraduate level, but these talks will also be useful for undergraduates in clinical years as well as medicine faculty, neurology faculty, students in family medicine, students who are working in a mission hospital or secondary hospitals. So this is a talk which will be widely useful. The talk is on localization in neurology, the philosophy of localization, and how exactly one goes about localizing in neurology. It's a wonderful talk, and I'm sure that you will be greatly blessed by this. Those of you who missed this talk, I know you probably are watching it on YouTube now, but we record these talks and put it on our Department of Medicine YouTube channel, and I think it'll also be available on the Neurology Department YouTube channel as well. So that's another site where this will be available. And please share it widely with as many people as possible. We hope to have these talks every week over the next 9 to 12 weeks. So please keep look out for these notices from the usual sites and our Department of Medicine website as well for these talks which are upcoming. So with these few words, I would like to also especially thank Hamsa and the team for Hasna and the team from telemedicine and Jennifer from medicine department who has arranged these talks very graciously. So I'm deeply grateful to Jennifer and Hasna and her team. So thank you all very much. And I hope you enjoy this 1 hour session with Prabhakar. Thank you.
Today we'll be talking about the principles of localization and diagnostic reasoning in clinical neurology. We'll start off with a little bit of philosophical background. So in this cartoon is depicted Plato's allegory of the cave. So I want you guys all to imagine that you were born and brought up inside a cave and you're chained to one of the walls and you can't come out of the cave. And the only things that you can see are shadows that are coming from the light that you see from outside. And all that you can see are just mere shadows. You really don't know what the real causes of the shadows are. So you don't know whether there's a bird or whether it's somebody holding up a bird, and you don't know the source of light. So all our knowledge, according to this allegory, is indirect information. So what we need to understand is that all our perception is through our sense organs, which we know are just not very good at picking up the entire world from outside. And what we perceive as real are mere shadows of real objects that are out there in the world. So let's assume certain things in the rest of the talk. So certain assumptions that we'll be making is that all perception is indirect, in the sense that we don't have any direct access to reality. And all observations that are made, because this talk is primarily a scientific talk, so all observations that we have made, including the one scientific observations, depend on the context. Because all we know is shadows interacting with each other, and how we understand are based on patterns of shadows interacting with each other. So context seems to play an important role. And because we're seeing only indirectly, all information that we gather is incomplete. And because information that we gather is incomplete, all knowledge that we hold is actually fallible. So in the sense that it can go wrong, and we can never be sure that we are 100% right. And this makes our understanding merely pragmatic, in the sense that whatever is understanding doesn't mean that it is actually real, but it is useful for us in everyday life, in solving problems in everyday life. So that is how clinical medicine works. All our clinical perception or understanding is through indirect symptoms and signs, and all our observations depend on the context. All clinical information that we gather is incomplete, and all clinical knowledge, including history, examination, the fanciest diagnostic tests are fallible, and all the use of clinical knowledge is merely for the benefiting the patient and coming to a diagnosis and not necessarily existent in the real world. So this is a philosophical background. Now let's look at the world in general. So if you look around you and science in particular, there's a whole kind of hierarchy of things that you can see. Starting from the universe above, there is the ecosystem, there's the organism, and amongst the ecosystem, there you find yourself, who has a body and who's made up of organ system. And as you go down, because we're talking about the nervous system, we're made up of neurons, synapses, neurotransmitters, all the way down to the DNA. And if you don't stop here, you can keep going down to atoms, electrons, protons, quarks, muons, and finally the empty spaces between them. So you see that there seems to be a lot that we do perceive in the world, and there seems to be some kind of order in the world. So there is some amount of predictability in the world. That's why science actually comes in helping us understanding this predictability in the world. We need to know that whatever we see is not the full picture, and there's lots more. So like, for example, lots we know about the ecosystem, lots we know about the body, but there is so much that we don't know between these two areas. Like, say, for example, we may know a lot about certain organ systems, but when we talk about, say, at the neurotransmitter level or at protein levels, our knowledge must be lacking. So we have a lot within a level, but between levels, our understanding is limited. So now let's briefly look at the scientific method, and then we'll try to see how we can apply it to everyday life. So what we do in scientific method is we observe reality. So we observe certain things. That means that we gather information without any biases first, and then we kind of try to understand what's happening, and then we generate a hypothesis. So once we do generate a hypothesis, we want to test it. So we do an experiment, or for example, in clinical medicine, you may predict whether a reflex will be exaggerated or depressed, and then you go and test it out, and then you go back, and then that becomes the next observation, and then that generates the next hypothesis. So this is a kind of ever recurring circle that goes on, and this is true about clinical medicine as well. So I'd like to talk about certain ways of scientific methods. Traditionally, science follows what is called as reductionism. So in reductionism, you take a complex system and you break it down into the constituent parts and understand them. Like, say, for example, you take the body and you break it down in the organs. Organs are made up of cells, and then you go deeper into the cells and you find that there are proteins, RNAs, organelles. So that is how reductionism works. But you'll find that there is a lot of missing information in our understanding. So very often you will find that this missing gap of information leads to a lot of errors, especially in diagnosis, because we don't know what's happening at one particular level. On the other hand, there's the newer methods in science is called the systems approach. In the context of clinical medicine, I would rephrase it as contextualism. So for example, you would understand what is the context in which this particular thing happens. You don't need to know all the information and all the finer details, but how objects are related to each other. So like, say, for example, how different components, like for example, within a level, so you can understand how certain neurons are connected to different neurons. You don't need to know what the neurotransmitters are or what the genes are involved. Another important way to bridge this gap between reductionism and contextualism is that another method called as a hierarchical reductionism. Say, for example, you fall down, so you go for a exercise and you have severe body pain. You're not going to say that there's a problem in the DNA. So you can explain it by saying that you worked out too much and you have body pain. Say, for example, you eat outside in a restaurant and you develop a gastroenteritis, then you can just say you have a gastrointestinal system disturbance. You don't need to go on to the subcellular level. Maybe you have somebody has developed behavioral symptoms of schizophrenia, then you may invoke the neural networks. And somebody with Parkinson's disease, you may go down to the level of neurotransmitters. So depending on the need, you go into one level deeper of understanding. and maybe you deal with somebody with progressive ataxic syndrome, and you may go down all the way till the DNA, and so on and so forth. So that is how we understand science and in the context of clinical medicine. So it may sound a little complex, but we'll get to the simple part here. So at the end of this, I would like you to conclude that there seems to be some kind of order in the world. So it's useful to follow the scientific method. And the most important thing is we don't have the full picture. And there are a lot of unknown facts, as we described. And yet a lot of things are predictable. So how to get around the unknown that is where statistics come to play and probability theory comes to play. So there's not much of maths in it, but in clinical medicine, there's one particular theorem that everybody needs to know, and this is nothing but the Bayes theorem. So the Bayes theorem is nothing but in order to make a diagnosis, you need to know certain probabilities. Say, for example, in this, let me just explain this formula. So what is given as P is the probability. So probability and A and B are certain conditions. So the probability of A occurring, given there is a condition B, depends on few other possibilities. So what is the possibilities? The probability of B happening given A. And also it depends on the probability of A happening independently and B happening independently. So in order to avoid this being so complicated, let's apply it in the clinical context, then it makes more sense. So let's say there's a patient who comes to you with a foot drop. So let's say, and we'll substitute B as an isolated foot drop and A is a stroke. So we want to know what is the probability of stroke given a foot drop. So a patient comes with foot drop and somebody calls you and asks you, do you think this patient has a stroke? So what does this depend on? This depends on the probability of a foot drop being isolated foot drop being due to a stroke. And most people who've been in medicine, you'd realize that that's pretty rare. You don't get strokes, usually don't present with only a foot drop. So you would think that that's pretty low. And what is the probability of stroke in a diabetic hypertensive person? Well, probability of stroke may be high. And also it depends on the probability of an isolated foot drop. And you would find that isolated foot drop is quite a rare condition. So overall, the probability of having in a patient who comes to you with an isolated foot drop, you would think that stroke is quite uncommon and you would not make that as your first diagnosis. So that is how you would not mathematically, but conceptually apply Bayes theorem in everyday life. Let's look at another example. Suppose instead of a foot drop, there's an isolated let's say an upper motor neuron facial palsy. So upper motor neuron facial palsy, will you make a diagnosis of stroke? For that, you need to see how common is upper motor neuron facial nerve palsy in stroke, and you would think that it's quite common. A lot of the strokes that you see in everyday life tend to have upper motor neuron, so the probability is quite high. Again, probability of stroke in a similar population would be diabetic, hypertensive, vascular risk factors is quite high. And probability of an upper motor neuron facial palsy would be quite high compared to a foot drop. So you would think that between an isolated foot drop and an upper motor neuron facial palsy, you would likely to consider a stroke in a patient with upper motor neuron facial palsy. And this is how you would apply Bayes theorem in everyday life. So now going on to the clinical diagnostic reasoning process itself, there are kind of two ways about thinking about clinical problems. So going through the analogy of the scientific method, so we start by observation. So we start with, in clinical medicine, we start with the patient's story or his story or her story. So you would find that you need to gather information. So the initial part of gathering information has to be filter free and not filled with your own theories and hypotheses. You should gather data. And that is when, after that, you need to accurately represent these problems. And this is where your knowledge and understanding of medicine comes in, and that's where context comes in. So, and there are two methods of understanding problems. So one is the analytical method. That's what you're taught in medical school. So you need to have a lot of background knowledge. That's why we have an entire medical curriculum where your background knowledge is built up over the years. And each problem has got certain defining features and certain discriminating features. And this is how you come localized to one particular problem. And on the other hand, as you go through your medical career as a clinician, you would realize that you're gathering experience and not just knowledge, but a lot of non-verbal things, a lot of things that are not there in books will also keep adding to information. And that would be something called as an illness script. So illness script is everything about the patient that is not just knowledge. So it could be the way they look, certain aspects, how common diseases behave, the context in which it happens, and also your own personal experience. So all of these will generate biases, and these biases will help you accurately represent the problem, or it's called the framing of information. And what helps you making a diagnosis rapidly in this intuition-based pattern is your bias. But unfortunately, the bias that helps you make the diagnosis also can lead to some errors. And later in this process, we'll try to find out how to avoid certain biases. And one way to avoid bias is to kind of switch between these two processes. One is the intuition pattern recognition based process, which is quite rapid, not very cognitively taxing. So as you gain experience, you can look at patients, come to a rapid diagnosis. But the problem is your biases may take you in the wrong direction. So you need to keep going back to the analytical method, making sure that you're not moving away from the right thought process. And sometimes the analytical process, on the other hand, is quite cumbersome. So it may not be practical to apply it in all patients. So it's very important that whenever you come across a patient who's slightly atypical, you have to systematically go through the analytical process and use certain measures like metacognition to overcome your diagnostic biases. Because in this setting, all your biases that helped you make a regular pattern will not help. So now going on to the simpler part. So we'll leave out the simpler. So we need to know that patient comes to you. There are with symptoms and signs. In neurology, we first try to figure out what are the anatomical sites that are involved. Then we say what is the physiological process that is affected. Then we say what the pathology is and what the etiology is. So you need to remember this hierarchy. So I talked about the entire organization of the universe, and each is a level in itself, and jumping between levels is a big problem because there's a big knowledge gap. And similarly, so when you start with symptoms and signs, to the anatomical sites affected, there's a big jump. And between anatomical sites and pathology, there's a big jump. And between pathology and etiology, there's a conceptual jump. So as far as possible, don't cross these barriers unless you're doing a formal way of thinking about these. So when patients come with a symptom, don't jump to an etiology. Always go through the systematical approach of going to the anatomy, then the pathology, then the etiology. So if you jump from symptoms and signs directly to an etiology, you would end up having what is called as a category error, and you'll be prone to much more diagnostic errors than if you follow this systematic way of thinking. So this is a safe and tested way of navigating this kind of hierarchical reductionism, and you will have the least probability of errors and the maximum probability of errors when you directly jump from symptoms to etiological diagnosis. So simplifying it a little further, so patient comes to you, they come with symptoms and signs, then you first localize it to a syndrome, and each syndrome has got an anatomical localization, and each anatomical localization, there are certain pathologies and etiologies you need to think about. So if all the previous slides are quite complicated, and now this is the time that you start paying attention. So now things are going to become more simple. So when somebody comes to you with a neurological symptom or sign, then we try to see whether these can be localized or non-localizable. By and large, most things can be localizable to a single site in the neuraxis or multiple sites. And the non-localizable sites are listed in this slide before, and we would never jump to them directly. So it's always better to try to localize to one of these sites and then go on to these non-localizable sites. So this is an important cartoon that I would like all of you to pay attention to. So this is a functional mapping or a conceptual map between symptoms and signs and the various sites of neuraxis. So in the left-hand side, you can see that various symptoms, syndromes, or clinical presentations. And on the right-hand side is the neuraxis. So what is given here is in dotted lines is an isolated involvement of one particular symptoms or sign. On a continuous line is a combination of symptoms or signs. So I'll run you through this, and this, if you follow this, you would find that you would make a reasonably good diagnosis in most clinical contexts. If somebody comes to you with isolated problems with awareness or cognition or cognitive decline, you are very likely that you are dealing with a problem with the cerebral cortex and not any other site. And if somebody comes to you with a loss of consciousness, it could be either two of these sites, thalamus or brainstem, and additionally a systemic cause that contributes to that. Suppose a patient comes to you with cranial neuropathy, which comes, again, if you want to understand it in terms of symptoms, comes to you with double vision, drooping of eyelids, swallowing difficulty, hiccups. So then you would consider when it's coupled with imbalance while walking or with weakness on one side, you would consider brainstem as a possible site. On the other hand, somebody comes with isolated imbalance, then you would think that cerebellum or its connections are involved. Now let's come to weakness. Weakness, if it is coupled with cranial neuropathy, you would think of brainstem. Weakness coupled with only on one side, you would think of lesion above the brainstem. Weakness, only weakness, you would think of an element condition. It could either be root, neuromuscular junction, or muscle. And isolated sensory involvement, you would think of nerve or root involvement. So, and if you have sensory motor and bladder involvement, this collection of symptoms you would most likely deal with a spinal cord. So this is actually a probabilistic model, and by and large you will be quite accurate. You also need to know that based on fallibilism, these boundaries that we've drawn here are not real. There will be overlap. These are just rules of thumbs, and there will be exception to every rule. But that doesn't mean that you don't follow any rule. So this is a useful model. Every time that you come across a patient, try to use this simple rule and you will be quite accurate. So now let's take certain specific examples. Let's take an approach to weakness. So we would approach weakness as either an acute weakness or a chronic weakness, because acute weakness, tone will not help us make a localization. The only thing that will help you is a pattern of weakness. And on the other hand, if it's a chronic weakness, then tone will also help, because a flaccid tone may tell you that it's lower motor neuron and a spastic tone will tell you it's upper motor neuron. And of course, the pattern will continue to help you even in a chronic condition. So what is shown in blue is a LMN kind of weakness, and what is shown in pink is actually upper motor neuron kind of weakness. So let's look at each pattern and how to localize them. So if you come with either a focal, multifocal, or weakness, or with monoparesis, and you have fasciculation as a dominant defining feature, very often you would end up with anterior Hansel involvement. So on the other hand, if you have focal, that is focal hand or limb weakness, or multifocal weakness with monoparesis, then you would think either a nerve or root involvement. Next, coming to a common pattern, you would get hemiparesis. So hemiparesis with facial nerve palsy on the same side, which we would call as an uncrossed hemiparesis. You would say the lesion is above the brainstem. It could be at the level of the internal capsule, corona radiata, or the cortex. On the other hand, if you come across hemiparesis with cranial nerve involvement, that is a crossed hemiparesis, then you would think of a brainstem involvement. So you can have quadriparesis. So quadriparesis or paraparesis, when it's coupled with sensory or autonomic involvement, then the localization becomes to spinal cord. And we have only quadriparesis. You need to see whether it's proximal or distal. So if you have proximal involvement with selectivity, then you would consider a muscle disease. If there is not much selectivity and it's predominantly distal, then you would think of multiple nerves. And if there is proximal and distal, then you will think of root involvement. If there is fluctuations or fatigability, then you would consider neuromuscular junction involvement. So this is a general rule of thumb. So when somebody comes to you with weakness, you see the pattern of weakness, see whether the tone is increased or reduced if it's a chronic disease, then you will be able to make a fairly accurate clinical localization. Sensory symptoms is quite easy, because the most useful thing in sensory symptoms is a pattern. Sensory symptoms can be positive or negative. Positive, both have localizing values. Positive symptoms can be tingling, paresthesia, allodynia, and sensory loss, numbness would be the negative symptoms. So isolated pattern along a single nerve, you would think of a mononeuropathy. If it's along multiple nerves, you would consider a plexopathy. Multiple nerves that are non-contiguous will think of a mononeuritis multiplex. So if it's along a dermatome, you would think it's a nerve root involvement. So if you get a level, in the sense that along the trunk or the neck or the limbs, always consider a spinal cord involvement. So it can be a complete involvement, it could be a hemicord involvement, or you can get a segmental sensory loss where you would think of a central cord involvement. And a glove and stocking paresthesias, you would consider multiple nerves or a polyneuropathy. And hemisensory loss, which is crossed, you would think of a brainstem, and uncrossed hemisensory loss, you will think of thalamus or above. So going on to another common syndrome that you would come across, very often you would come across patients with cranial nerve symptoms, So when there are cranial nerve symptoms, which in the common symptoms wise, you would get double vision, drooping of eyelids, a squint. So you may get facial palsy, facial weakness, swallowing difficulty, hiccups, or vertigo. These are all the cranial nerve symptoms that you would come across. So whenever that cranial nerve symptoms are there, along with weakness or ataxia, you would consider a brainstem syndrome. And once you say it's a brainstem, so unfortunately for clinical localization, you don't need to know all the intricate anatomies. So all you need to know is that 3 and 4 cranial nerves are there in the midbrain, 5, 6, 7, 8 are there in the pons, and 9, 10, 11, 12 are in the medulla. And also you need to know a little bit of gaze. So vertical gaze is controlled by midbrain and horizontal gaze by the pons. So in order to make a vertical diagnosis, so you need to work vertical level. So once there's suspect of brainstem involvement, you see whether the 3rd, 4th cranial nerves are involved along with vertical gaze palsy, then you would say there's a midbrain involvement. If the patient has got a crossed hemiparesis or 6th or 8th cranial nerve involvement, then you would localize it to the pons. If 9th, 10th or 12th are involved, then you would, or hiccups, then you would localize it to the medulla. The next way to localize the brainstem syndrome is whether it's medial or lateral. So in most sites and then along the brainstem, you would find that the corticospinal tracts are medially placed and the cerebellar tracts are laterally placed. And if you get ataxia, which is a symptom of cerebellar tract involvement, you will think that it's a lateral brainstem syndrome. And if you get hemiparesis or quadriparesis, then you would think that it's a medial brainstem syndrome. So 2 common syndromes that anybody in clinical medicine should know is a stroke syndrome. Stroke syndrome is somebody with an acute onset focal neurological deficit. You need to consider us involving the CNS. You need to consider a stroke syndrome. And the first thing you need to do is rule out whether it's a stroke mimic or not. And next question that you ask is it an anterior circulation stroke syndrome or a posterior circulation stroke syndrome? And an anterior circulation stroke syndrome is characterized by an uncrossed hemiparesis, or that means that the hemiparesis and the facial nerve palsy is on the same side. They may have monocular visual loss, they may have language symptoms, they may have neglect, but the defining feature is hemiparesis, which is uncrossed, or the facial nerve palsy is on the same side. So the next question that you need to ask is there dense hemiplegia or not? Dense hemiplegia means grade 0 or 1 par in both the upper and lower limbs, and that tells you that an area that is covered by both upper limb fibers and lower limb fibers are affected. The common sites are the internal capsule and the brainstem. Because the patient does not have any other brainstem symptoms, we'd say this is a localized to the internal capsule. If there is no dense hemiplegia, that means there has to be differential limb weakness. Either the upper limb is more involved or the lower limb is more involved. If upper limb is more involved, then you localize to the lateral part of the cortex, which is supplied by the middle cerebral artery territory. If not, if lower limb is more involved, then you localize it to the anterior cerebral artery territory. Next thing you see is whether the cortical signs are present or not, which is aphasia usually in the left hemisphere and neglect on the right hemisphere, plus minus seizures. So if cortical signs are there, then you would localize it to the cortex. So another thing which is not mentioned here is that you can have dense hemiplegia and cortical signs. Then you would say that both internal capsule and the cortex is involved, which most likely tells you that a possible site of involvement is a proximal vessel, which is usually the internal carotid or the middle cerebral artery. Similarly, posterior circulation stroke, the algorithm is very simple, exactly the same as a brainstem syndrome. Only 2 other sites that you need to consider is in patients who develop visual loss or unexplained loss of consciousness. So you find that either if the patient has a low level of consciousness or isolated hemisensory symptom, then you need to localize it to the thalamus. And if the patient has got a visual field defect or a higher order visual symptom, then you would consider an occipital cortical involvement. Otherwise, the approach to posterior circulation stroke is exactly like a brainstem syndrome. Okay, now let's apply whatever knowledge that we've discussed now into certain cases, and I'll take you through some of the cases, and you guys can also contribute. So our first case is a case of a 60-year-old man who had come with difficulty in walking. He had some tightness of the limbs, tripping over objects. His weakness started in the foot, and he also developed decreased sensation below the chest. He also developed bladder symptoms in terms of urinary urgency and incontinence. And now he's also developed low back pain. So applying this, let's say where he's got one thing while applying diagnostic reasoning is that the human mind is used to dealing with concrete objects and small number of objects. So decide as far as possible, divide things into one or two or three categories and try to keep it simple. Only go into the next level of understanding if the current level cannot explain all your findings. So here, let's say this patient has got, I'm not trying to see what pattern of weakness, where is there, what is involved. So I'm just going to say motor, sensory, and bladder. All three are involved. And most likely you're dealing with the spinal cord involvement. So that's all the information that is needed. All the other information is needed at the next level of explanation, not at this level. So when you say motor, sensory, and bladder, maybe there's a level because it's got a high discriminating feature. You will say that this patient has got a spinal cord involvement. Now, going on to the pathology and etiology, very often pathology and etiology is given by the temporal profile of things. So if things happen in seconds, then you think of a vascular event or a trauma. If it happens over days or weeks, you'll think of autoimmune infections. Subacute causes, you will think of toxic. And chronic, you will think of slow-growing tumors, genetic and degenerative etiology. And this is across symptoms and signs and across specialties. So this is something that you can be used all over. So let's go back here. So the next level of understanding is that where exactly in the spinal cord is it involved. So here, let's see that this patient's weakness started at the foot and then gradually progressed up. And the decreased sensation started from the foot, progressed to the chest. Loss of sensation was there noted in the perianal region, and patient had bladder involvement, also had low back pain. So the next level of understanding is that what is the horizontal level of the cord, in the sense that is it an intramedullary lesion or an extramedullary lesion? Before that, we need to know whether it's a compressive lesion or a non-compressive lesion. So whenever there is two or more tract involvement and there is a localizable level, always consider a compressive etiology. There's no way that you can rule out a compressive etiology by reasoning. So if there is a level and if there are more than two or more tracts, always consider compressive. And this reasoning is, of course, for only insidious onset, gradually progressive lesions, but it's just a rule of thumb. So there are ways of differentiating intramedullary and extramedullary lesion. So in this particular patient has got kind of an ascending pattern of weakness, ascending sensory loss, no radicular pain, but there is sacral sensory loss, and there is bladder involvement, which is quite late in this case. So between these two things, I would choose that this patient has probably got an extramedullary compression. And this is what the imaging showed. So this is a 60-year-old man. When we summarize, it's very important to frame the case summary so that the person who's listening to you is able to come to the same localization without having to go through the entire process of taking history and examining. So this is a 60-year-old man who's come with paraparesis, which was ascending, and has got a decreased level at the mid-chest with urinary incontinence. So that localizes to the spinal cord. And what is the pathology? There's clear-cut level, and there are two or more tracts that are involved. So it is a compressive etiology. And in view of the ascending pattern, we said it's an extramedullary pathology. In this patient, it happened to be that this patient had multiple myeloma and there was a plasmacytoma at that particular level. So that is the diagnostic process. So we were quite accurate in localizing it to the spinal cord by just looking at only three features: motor, sensory, and bladder. The co-occurrence of this itself localized to the spinal cord. All the other information we fitted in only in the next level of localization, and that way we avoided a category error. So next is a patient where it's a 25-year-old lady who's got fever, headache, vomiting for 3 weeks. Following this, she developed sudden onset of weakness on one side of the body, along with double vision, and she's not able to open her left eye. So again, we'll keep it gross because always start with general symptoms. So this patient has got cranial nerve involvement. I'm not going to bother which cranial nerves are involved. And this patient has got cranial nerve involvement along with weakness. So it has to be in the brainstem. So that's all I need to do. Next step is to apply this. So I'm going to say that this patient has got cranial neuropathy, which is double vision here, and also has got drooping of eyelids, and has got hemiparesis. So fulfills the criteria for a brainstem syndrome. The next two questions are where in the brainstem is involved. So I'm going to see this patient has got third nerve involvement because of ptosis. Diplopia would localize to either third or sixth. So here I would think that the midbrain is involved. So on examination, we also found that vertical gaze is gone. So maybe midbrain is involved. Next, I want to know is whether it's a medial or a lateral syndrome. This patient has hemiparesis. So straightforward, our localization is to a medial midbrain syndrome. So it's quite, here again, diagnosis becomes easy because we started at a simple level with few features. Now we are going into the next level of localization. So if you directly jump to a midbrain syndrome, then you would have found that it's much more difficult to localize. So now let's go on to again. We found that this patient has got a medial midbrain syndrome. So this patient has a left third nerve palsy, right hemiparesis. Our anatomical localization was to the brainstem because of cranial neuropathy with hemiparesis. Then we said midbrain because third nerve was involved. Because hemiparesis was there, we said it's medial midbrain syndrome. And then clinically, we said this is a Weber syndrome. And this is the anatomical localization that we got because that is where the third nerve and the corticospinal tract fibers are together. And when we going on to the etiology, we said this is acute. I mean, it was quite subacute. So we'd think of, especially in the context of fever, we'd think of an infection that is going on. Patients had fever and headache. We would think of a meningitic process that would fit into an infective etiology. And that's what we found. So this patient had a Weber syndrome, a medial midbrain syndrome. And the etiology in this patient was a tuberculous meningitis. So we found that the etiological diagnosis came in the end. So we would not jump to an etiological diagnosis at the beginning of the history itself. So that way we avoid category errors and diagnostic errors. So going on to the case number 3. So this is a gentleman who came with neck pain, arm pain, and weakness of all 4 limbs. Patient had a sensory level in the mid-chest level, and patient had a bladder involvement. So where would you localize? Keeping it simple, we would say motor, sensory, and bladder has to be in this. In the spinal cord, has all 4 limbs involved, so it has to be in the cervical spinal cord, and that's what the imaging showed. And we would call this particular imaging pattern as a longitudinally extensive transverse myelitis. So this patient was admitted to us, and this was days to weeks. So we found, and patient had fever at onset. So we thought maybe it's an infection because previous patient also was tuberculous meningitis. We were worried what it was. And we ended up with a diagnosis of neuromyelitis. So we started the patient on ceftriaxone. We did a CSF. While we were waiting, we found that the patient's aquaporin antibody came positive. So this is where we need to stop and think. So we ended up with a diagnostic error. So if you're wondering why did we end up with neuromyelitis, let's look at this. So this is where we'll apply the Bayes theorem. So let's say the probability of myelitis in a case of LETM is proportional to the probability of LETM due to myelitis. So an LETM is not a common, it's not an uncommon entity in neurology. So we've seen hundreds of cases over the years, and in a month we would easily see 1 or 2 patients. So, and we've seen only about 3 patients with neuromyelitis over the last 5 years. So in order to make, if you see an LETM, making a diagnosis of neuromyelitis, you need to reflect on what proportion of your LETM is due to myelitis. So if the number of patients due to myelitis causing an LETM is very, very low, be wary of making a diagnosis unless you find something, some defining characteristic that is very, very specific to neuromyelitis. Of course, there are some like restriction of cranial nerve nuclei and certain extension along the tracks, but this patient did not have any of those. On the other hand, let's take neuromyelitis optica. So myelitis optica as a cause of LETM is very, very common. So if a patient comes with LETM, what is the probability of having neuromyelitis optica? Of course, the probability of neuromyelitis optica itself in the neurology ward is quite high because we see it quite common. We see hundreds of cases. And again, probability of LETM is quite high. And the probability of having NMO and LETM again is very high. So it's most likely that this diagnosis has to be an aquaporin positive. But why did we make this mistake? Of course, we were biased by the previous patient with tuberculous meningitis who had an infection. And in our ward, this is a real patient where we had 2 cases of neuromyelitis, which we missed initially. And one patient was actually admitted with neuromyelitis at this point. And this is called as the availability bias. So because the most recent and readily available solutions come into your mind. So we gave too much importance. This is where actually applying the Bayes theorem would actually help such prevent us from making these diagnostic errors. So this is a case that I claim to have seen in OPD. So This is a 20-year-old lady referred from Shell with headache and papilledema. And I looked at her fundus, there was papilledema, and I saw the imaging. I was quite convinced that it was an IIH. I did a CSF, opening pressure was 30, and I started her on astazolamide. And she came back to OPD a couple of days later and told me, doctor, my local doctor said that my blood pressure is high. So I told her, I said, don't worry, when your intracranial pressure is high, your blood pressure will go up to compensate, and sent her off. And 2 days later, she was admitted with a hypertensive crisis with emergency with a flash pulmonary edema. In fact, what she had is a accelerated hypertension with hypertensive crisis, and she did not have IIH. So here again, this is a confirmation bias. So I already assumed that this patient had an IIH because this patient was referred from Shell. So the context, so all the biases that help you make a diagnosis also will lead you astray. So a patient referred to Shell with papilledema in the neurology OPD is always an IIH, hardly anything else. So I assumed that it was an IIH and treated as an IIH. I did an LP, opening pressure was high, so I was convinced. So the cell count was normal, I was convinced. But I didn't give importance to negating information that the blood pressure was high. So if I had thought about why the blood pressure was high, then I would have found out that she had a glomerular nephritis and she had an hypertensive crisis and not an IIH. So you need to be aware of a confirmation bias. So that's why you need to systematically use the metacognition to overcome such confirmation bias. So this is a patient who's currently in our ward. So this is a 30-year-old lady who came with monocular, some pain in the eye, which was noticed while moving her eyes, and monocular visual loss. Young lady with visual loss, monocular visual loss is quite easy to localize along the pathway. So we had said that this is an optic nerve involvement. Young lady, pain. She had some mild ocular disc swelling. So we decided that she has an optic neuritis and we started her on steroids. So, but then when we went back, we found that there is some problem. So we found that we went back and got history and we found that she's got chronic headache. Before this symptom started, she had left eye pain and intermittent diplopia. And this diplopia, there was horizontal separation of images. And following this, she developed monocular visual loss. Of course, additionally on examination, we found that she had the left Horner syndrome. She had some pain over the V1 dermatome, and she has an RAPD along with that. So instead of just saying optic nerve, now we were able to localize it to the orbital apex, which, because the fact that she had double vision, which is a cranial nerve involvement, only site where optic nerve and other cranial nerves such as the third and sixth are involved is in the orbital apex. And we found that she's got an inflammatory disorder involving the cavernous sinus and the orbital apex, most likely IgG4 or one of those spectrum of disorders. And we found that the cause of this in view of the chronic headache was a chronic inflammatory disease affecting the meninges, in this case, a pachymeningitis. So this is called as a search satisfying. So if somebody called me and said that 30-year-old lady has come with monocular visual loss, then I said, must be optic neuritis. So my team said, yes. So I also just stopped searching for any other cause. And that's how we ended up with a bias called search satisfying. So whenever you get a straightforward case, always ask yourself, are we missing something? Is there another diagnosis that is going on? So now let's look at how we can avoid such scenarios. So one common theme in all diagnostic error is that inadequate history. So if you start applying your theories and hypotheses before you get history, you will always get a confirmation bias. So it's important to spend time, especially in a complicated patient, to get filter-free history. So I'll come to what you mean by a filter-free history is. Another thing is the premature closures. Like the previous patient with the optic nerve problem, so we had a premature closure. We already decided that is an optic nerve involvement in this. And the other thing is category errors. So when this patient came with monocular visual loss, I said optic neuritis. So that is jumping directly from the symptom to the etiology without going through anatomy, pathology, and etiology. So if I had gone through the anatomy, if I had said optic nerve and what site of optic nerve was involved, then I would have gone back and asked more history from the patient and we would have localized it to the orbital apex. We would not have jumped. So that is exactly what I mean by a category error. And ignoring the base rate. So for example, in neuromyelioidosis, if overcalling a diagnosis, when you know that particular disease is very, very rare, so that's another problem. And improper use of discriminating or defining features. Say, for example, like perioptic halo is a common condition that we'd see in a lot of our patients who have normal imaging, and very often they get referred to as idiopathic intracranial hypertension. So that may be a common finding, which does not have so much of discriminating value. So this is something that you need to gain by experience and reading up more and doing more research, because each defining feature and discriminating feature will vary across tests, vary across populations. And another important thing is not updating clinical knowledge through feedback. So you should always be open to clinical diagnosis, always follow up your patients, make a diagnosis. If you're not going to make a diagnosis, you won't know whether you're right or wrong. Follow them up to see whether you're right or wrong, because we're always good at learning from mistakes, learning on from follow-up. So otherwise, you will be making the same mistakes again and again. So let's look at avoiding diagnostic errors in clinical diagnosis. So how would you do this? The most important thing, that I put it in red so that that's the most important point, is to get a reliable history. So get the context, because context of who, when, how, what, because context is everything, and context lies in the history. So history is the single most important thing, and the history should be so good that you are able to visualize the entire scene of what the patient is describing like a video in your mind. You should be played out. You should know where things are, what is happening. And if you're not able to do that, that means your history is not reliable. You should not give too much importance to the history. So, and a relevant physical examination. So we are always happy to examine just to rule in a particular diagnosis. So if you're thinking of a UMN sign, if you're LMN syndrome, not just looking at wasting, you should always look to rule out. So look for UMN signs, look for exaggerated reflexes, increased tone, and also learn to observe phenomenology. So this is where the filter-free history and filter-free examination comes in. So at some point in time, when you realize that you're not dealing with a typical patient, just let go of all your theories and understanding and just try to put yourself in that patient's place and try to examine, experience the entire scenario of how it's happening. So let them tell you all the details. This is when visualizing the entire history as a video helps. And also observe the phenomena. Very often, a lot of clinical phenomena don't try to categorize them as a movement disorder or a particular disease or a particular jerk, so just observe the phenomenon and just describe it. And later, then you can try to understand it. And that is how new clinical knowledge is also found. And keep it simple. So as we saw in some of these, so we just said core features, just take them, localize it to simple things like spinal cord. Only then go into intramedullary, extramedullary, and those finer points. And the use of metacognition. Metacognition is nothing but thinking about thinking. So how can you do that? Some of these things are just checklists. So did I take a history? Did I take an examination? Did I check the fundus? So you should have a checklist or a systems review in the traditional way of examining patient. Or another thing that our area of research, and it's something is that we want to emphasize, is the role of inner dialogue. So all of us in our minds always have an inner dialogue, and it's important to use this inner dialogue to the benefit in clinical medicine. So you always ask yourself certain questions. So I just listed some of these questions. There could be more. So it's always important to ask, what is my anatomical localization? Every symptom that you see, every symptom that the patient says, always ask, what is my anatomical localization? And another important thing is, what are the alternate anatomical sites that could be involved? So this way you can get over your confirmation bias and premature closure. So by asking these questions, if your knowledge is good and your experience is good, your mind will give you answers to these questions. So, and what are the possible pathologies and etiologies at each of these sites you need to think about, and always make a verbal statement of what is my diagnosis. So very often in a complicated case, you would not want to spell out your diagnosis. You just move on to investigations. Always spell out your diagnosis. It's important to make a diagnosis. It's important to, even if it's wrong, unless you make the mistake, you're not going to learn from it. And two other important things that are important is to assume that your history is wrong. Then consider what is the alternate diagnosis. And assuming my examination is wrong, what is the alternate diagnosis? So, and if you're not able to sort it out, you're always, I said, context is everything. So you always had a fixed point of view. Show to another person, a peer or somebody senior, and don't tell them what you're thinking. So don't tell them that, I have this case of optic neuritis, can you see? So don't bias them with your information. So let them have an independent view and come to their conclusion and see whether you can match. And whenever there's a difficult problem, always use the Bayes rule, not in terms of finding probabilities or likelihood ratios, just conceptually thinking about it from your clinical experience. And most importantly, be humble. Nothing kills clinical skills like overconfidence. Remember, all knowledge is fallible. Yeah. Thank you.
Thank you so much, sir, for this wonderful lecture. I think if we have some time, can we take some questions?
Yeah, I'll be happy to take questions.
Anybody has questions, they can ask now.
Hi, Prabhakar. This is Tarun here.
Hi, Tarun.
Thank you so much for this really excellent lecture. It's something that we all kind of have intuitively in our heads, and it's really nice to see you, tease it out, and also your slides. So I think one is, how did you create those slides? What was your experience in coming through with this? But a more neurologically localizing question is, in situations where you have, disorientation and cognitive involvement, how do you approach localization?
Yeah, Tarun, thank you for your question. So I'll address the question about disorientation. So the simplistic model for cognition is what I'd like to call the umbrella model. Actually, this is taught to me by George Johnson. So you can imagine brain is like an umbrella. So you have a handle and you have a canopy. So the metaphor for the canopy is the brain and the handle is the brainstem. So if you have a problem in consciousness or orientation, so either there has to be a problem with the handle or there are multiple holes in the canopy. So unless you are able to open out the umbrella, you won't know whether there are any holes in the canopy or not. So that means I'd like to define two concepts. One is called as state functions and the other is called as channel functions. State functions depend on the reticular activating system, systemic factors like metabolic parameters, oxygen level, glucose, whether there's sepsis or not. And channel functions are various brain functions like language functions, attention, orientation. So only if your state functions are normal, you can actually test other channel functions. Only if you open up your umbrella, you will know whether there are holes in the canopy or not. So if there is a problem with consciousness, the two things that you would consider is there a brainstem problem or bilateral cortical problem, or it's a systemic cause. So that would be a simplistic approach to disorders of consciousness and orientation. But if the patient is disoriented or drowsy, you can't really comment on language functions or aphasia or visual functions. So that's also another corollary to it. So.
Prabhakar, Tambu here.
Yes, sir.
Thank you very much. Thoroughly enjoyed your lecture. So I think a lot of people will benefit immensely from this localization. Somehow, I wish our medical students also get a chance to listen to your talk. So with your permission, we'll share the video with medical students as well.
Yes, sir.
I hope it's okay.
Yes, sir. Yes, sir. Thank you, sir.
So, and I also want to thank you because you personally arranged so many lectures for us over the coming weeks. So I just want to tell all the participants as well that thanks to Prabhakar, we have a series of 13 lectures. So every week, just look out for the notices from Jennifer and Prabhakar, and please come back and listen to these lectures. You can listen to them on our YouTube channel as well. Prabhakar, very honored and very happy with the lecture. Thank you so much.
Yeah. Thank you so much, sir.
Okay. Thank you all. And we hope to see you again next week for the next lecture. Are there any more questions in the chat box we have missed? I think there are no more questions in the chat box. So we'll end the lecture now, Jennifer?
Yes, sir.
All right. Okay. Thank you, Jennifer.